Okay, so good afternoon, everyone, and welcome back to those who are joining us for our first session of the day, which was on bone health and neuromuscular disorders. Today's session will be on cough, respiratory health, and neuromuscular disorders. This is day 6 of our virtual neuromuscular conference and our last day of our virtual neuromuscular conference. Before I go into introducing our speakers, I did want to mention that on your screen, you will see an interpretation icon. You can go ahead and select that icon and select English or French. That will allow you to listen to today's presentation in English or French. I'll pass it over to my colleague, one of our service specialists in Quebec, Véronique Panchaud. She'll explain this instruction in French. Go ahead, Véronique.
Merci, Amira. Alors, je vous souhaite la bienvenue à cette 6e journée du colloque des maladies neuromusculaires. Merci de vous être inscrits à la présentation d'aujourd'hui portant sur la santé respiratoire des personnes atteintes de maladies neuromusculaires. Alors, donc, je voulais vous informer que cette conférence est disponible dans les 2 langues, tant en anglais qu'en français. Alors, pour choisir votre langue de préférence, là, vous n'avez qu'à cliquer sur le bouton en bas de l'écran en forme de globe terrestre. C'est le bouton d'interprétation et vous pourrez choisir la langue désirée. Donc, sur ce, bonne présentation à tous.
Thank you very much, Veronique. So today we have Dr. Janice Richmond-Eisenstadt, who is a pulmonary rehabilitation medicine and palliative respiratory care specialist in Edmonton. She's an associate clinical professor in the Pulmonary and Neurology Divisions, Department of Medicine at the University of Alberta. She and her colleagues started the first multidisciplinary neuromuscular clinic for adults in North America. She also provides consultation services to multidisciplinary teams of the ALS Clinic, Spina Bifida Clinic, Lung Disease Clinic, the Norwood Chronic Ventilator Unit, and the patients in their homes with the Edmonton Zone Home Living Program. Dr. Janice is an excellent supporter of MDC. We appreciate the support that she's given us over the years and the time and information that she'll provide us today. So I'll go ahead and stop sharing my screen so that we can hear more about cough assist, about respiratory health, and I'll pass it over to you, Dr. Janice.
Hi, can you hear me now?
Yes, go ahead.
Okay, thank you, Hamira, and thank you to Muscular Dystrophy Canada for asking me to talk about a subject that I'm quite passionate about, cough, respiratory health, and neuromuscular disease. So as Hamira mentioned, I'm a lung doctor and I specialize in neurological conditions that can or do affect the breathing. And I take a rehabilitation perspective, a rehabilitation medicine perspective, in that my focus is not just on the lungs or the breathing, but all of you, and how do I help maximize your quality of life? So I want to start very simply. What does the respiratory system do? It's so complicated. We breathe in, we breathe out, we cough. That's the big summary. However, when we have neuromuscular disease, it can affect a variety of muscles that impair our ability to breathe in, breathe out, and cough. And it can get to the point where we now multitask, because when we talk, it's just not that we talk, we're breathing and talking. The respiratory and normal respiratory system and normal muscles are important for the ability to eat, to chew, to swallow in a way that directs the food into our stomach, where we can digest and absorb the food, and not into our airway where we can't digest and absorb the food. We need to be able to blow our nose, have a clear nasal passage and clear sinuses so we can smell. Then we also have to deal with secretions. Where do these secretions come from? Is it from the nose? Is it from the mouth, too much saliva because we have impaired swallow? Or is it from the lungs? Either because we can't take a deep enough breath and help move those secretions up and out, or because we have some other lung disease that affects the ability to manage those secretions, or we produce too many secretions. And really importantly, do we have the ability to cough? Take a deep breath in, use our abdominal muscles, use good glottic function, that's the throat here, the throat muscles, to take a deep breath, and then forcefully expel whatever's in our chest or at the back of our throat. And do we have the ability to manage chest infections so that we can breathe in and out normally through the chest infection, have a good immune system to fight off the infection, and cough and clear those the germs that are causing the infection. The other thing we need to do is not just breathe during the day when we eat, talk, dress, move, toilet, have fun, work. We also breathe when we sleep, but breathing during sleep is very different than breathing during the day. And people might say, oh, I breathe just fine during the night. You know, I wake up and I find that I'm breathing just fine. Well, no, if you're awake, you're awake. Your breathing is different. When we sleep, our breathing is different. There are different stages of sleep. And when we go into really deep sleep, dream sleep, all our muscles relax, except our diaphragm, the most important respiratory muscle, the strongest respiratory muscle, and our heart muscle. Now, if we have normal muscles, nerves, chest wall shape, then we're able to go in and out of the different stages of sleep with adequate oxygenation, the ability to blow off our carbon dioxide, and then we wake up feeling refreshed. However, at a certain stage in neuromuscular disorders, if our muscles are weak or our muscles tire easily, we may lose that ability to go in and out of the different stages of sleep. And we start to accumulate carbon dioxide because we're not breathing in and out effectively. Blowing off the carbon dioxide tends to accumulate, and we'll feel tired, might have a headache in the morning, or we'll feel really grouchy during the day. And this is something that can creep up on you really, really gradually and slowly without you knowing it. So you might think, no, I don't have any problem with breathing. See, I'm awake. But the only way to know really is, one, to check the carbon dioxide level that you have during the day in the blood, which is the most accurate way, or to do a sleep study. And in adults, we can do a screening home sleep study, but sometimes we really have to do a detailed sleep study in the lab to know exactly what's going on with your breathing. And when I see people, I want to know, how are you living with the lungs that you have? Can you talk, eat, swallow, blow your nose, breathe in, breathe out, cough, sleep? So when I examine you, I'm going to be listening to your speech, to your language. I'm going to be examining your head and neck. Can you breathe through your nose? What does the back of your throat look like? Do you have the ability to move your tongue and your lips and keep your mouth closed tightly? I'm going to listen to your chest. Can you take in a big breath? Do you have any crackle, signs that you're accumulating secretions? I'm going to listen to your heart, because neuromuscular disease can affect the heart muscle in some cases, and both the heart and the lungs interact very closely together. I'm also going to check your hand function. Do you have the ability, do you have the strength in your hands, to be able to do some of the exercises I'm going to tell you? Do you have the ability to put on your glasses and remove your glasses? Do you have the ability to feed yourself? Because this has implications if I'm going to be starting you on some breathing support during the night called Bipap. And then I'm going to do some tests. I'm going to want to know what your oxygen saturation is. I can do it with this little gadget. And then I want to know what your carbon dioxide level is. Usually I screen people by measuring the carbon dioxide in the breath. That's really easy and it's painless. But if I have any suspicion that you're in respiratory failure and your carbon dioxide level is high, I'm going to need to do a poke at the wrist called an arterial blood gas to know exactly what the carbon dioxide level is. And if it's high, it means you're in respiratory failure, and we need to do something about that, because doing something about it will improve your quality of life. The next thing I'm going to do is check your respiratory muscle power. How forcefully can you inhale? How strong is your exhale power? I'm going to measure your peak cough flow with a peak flow meter. Those of you with asthma might have one of these just to measure your peak flow, to measure any airflow obstruction. But this is quite a nice gadget to actually put a number to the strength of your cough. And the way it's used is it's very simple. I just take a deep breath in and I cough, not a blow, a cough. and I can push this red marker up well past 270. If your peak cough flow is 270 liters per minute or below, I start to worry you may not have a good enough strength to cough and clear your airway. The next thing I'm going to do is ask the respiratory therapist to measure how big a breath you can take in. That's with bedside spirometry, measuring your vital capacity. That's just basically how big a breath you can take. And I'll also measure how the volume of air you can get out in the first seconds. That speaks to whether you might have any airflow obstruction, as might occur in COPD or asthma. Now, in addition to those tests that I can do when people come in to see me, I might also need to review how you're using any inhalers that you might be on. Do you have the whiffing power, the strength, the muscle strength to inhale your medications? If you're on machines or equipment, how do you get those medications into you? Because if you don't have a big enough volume of air that you can move in and out, how are you actually delivering that medication to deep within your lungs so that it's delivered effectively? And then I may order, if I have any suspicion, I'll order a home sleep study or a sleep study in the lab. Typically, I start with a home sleep study. I like to do this on most of my patients as a screening test. And if I have any suspicion about the effectiveness of your swallow, I may work with a dietitian to send you to a speech language pathologist to actually study how effectively you swallow. Please note that even though we think, most of us would think that if we swallow incorrectly, we'll be aware of it. Not necessarily. There are people who can swallow and have no idea it's going into the lungs. And that's not a good thing, because over time, if you cannot cough and clear effectively or swallow properly, that can cause aspiration pneumonia, bronchiectasis, chronic respiratory failure, scarring of the lungs, not good stuff. And then I figure out, well, how are you doing? Are you able to prevent chest infections? Are you keeping yourself safe? You know, are you avoiding risk factors? Do you work in an environment that's not healthy for your lungs? And if you do, are you wearing protective gear? Are you wearing the right mask? Or do you smoke? Smoking is not good. You can't control whether you can't control that you have a neuromuscular disorder, but you can control whether you're a smoker or not. And smoking any burned organic matter does not make the lungs happy. The other thing is, do you know how to avoid chest infection? Washing your hands, wearing a mask when, especially during this COVID pandemic, staying physically distanced, and feeling very comfortable to tell people that if they are sick, no, they should not visit you. Are you getting vaccinated? Do you have your flu vaccine? Do you have a Pneumovax? Are your other vaccinations up to date? Those are all important things to keep your lungs healthy. The next thing I want to talk about as very important for keeping your lungs and your chest, your breathing healthy is maintaining your lung volume. So let's say I measure your lung volumes and they're not between the 80 to 120% predicted. That is within the normal range for someone your height, age, gender, and ethnicity. I want you to start doing some range of motion exercises for your chest wall. So for example, if you have an arm that's weak, the joint stems will contract. And so then you want to do stretching exercise to make sure that joint doesn't stiffen up, because the same principle can apply to your lungs. If you're not able to take a deep enough breath over time, your chest wall is going to get more restricted and you won't be able to take as deep a breath. And now you'll have weak muscles trying to move a stiffer and stiffer chest wall. So I want you to start doing range of motion exercises for your chest wall. Well, how do you do that? If I want to do range of motion exercise for my arm, I have to exert an external force and stretch out that joint, stretch the muscle. How do I do that for the chest wall? Well, that means I have to exert an external force with what's called lung volume recruitment or breath stacking, where effectively I take a deep breath in and then whatever I can't do on my own, I'm pushing air in so that I can get a full stretch. And this is what it looks like. So most of my patients don't need the nose plugs, but I still use them because I want to be sure to direct the air into my lungs and not out my nose, which would not be a pretty sight. So I have a bagger too big, extender too big, add a gadget with a one-way valve. So this is not for resuscitation. So that when I push air in, it goes in, it doesn't come right out the tube. And it's very simple, a matter of. Watch again my chest wall. Now, if I have a weak cough, the other thing I can do, if I have a weak cough because I can't take a deep breath, I can use that bagger to help me take a deep breath and cough more effectively. So this is a great way for range of motion exercise for the chest wall to keep a compliant bendy chest wall, which makes it easier for my muscles to open and move my chest wall and can give me more effective cough. Sometimes this isn't enough and I need to do a manually assisted cough, or I need someone else to help me cough by them doing a manually assisted cough. And I ask the respiratory therapist to help teach caregivers and patients how to do that manually assisted cough. Some can do it on their own, some need help. This gadget is called the Lung Volume Recruitment Apparatus, or LVR for short. I also collect nicknames that my patients have for their blue bagger or their football or their bagpipe. But this is a great gadget. Now, sometimes, however, it gets to be too much work when you have a lot of secretions to use this. By the way, I recommend people do this 4 times a day at a minimum, before breakfast, lunch, dinner time, and before bedtime. That's at a minimum. And it takes about 2 minutes to do 5 full stretches, and that seems to be enough to maintain vital capacity and slow down the decline in vital capacity over time that occurs with neuromuscular disease, and to maintain a nice compliant chest wall. Because remember, the more compliant your chest wall is, the easier it's going to be for me to prescribe breathing support or BiPAP, non-invasive breathing support at nighttime or during the day if you also need breathing support during the day. I won't need as high pressures to move that chest wall to open it up. But at a certain stage, if this is not enough, or it gets too tiring, or it's not possible to coordinate, then I recommend the mechanical inexsufflator, also known as a cough assist. And I don't like the name cough assist, but they had to do that for trademark issues, because it's not just about coughing. It's about that range of motion exercise, as well as the ability of clearing your lungs. And I really like the cough assist because I can give you 3 different settings: one for routine lung volume recruitment, the second for augmented airway clearance. You got some extra chest walls, you got some extra chest secretions, maybe you're coming down with a cold, maybe it's just a bad day. And then the third one for respiratory crisis. Oh my goodness, something's gone down the wrong way, you want to get it up and out quickly, or you've got a mucus plug. Now, the other important thing for airway clearance is keeping well hydrated. You've got to drink enough water. If you don't drink enough water, those secretions in your lungs can get very dry and even more difficult to cough and clear. In addition to using this or your mechanical inexsufflator for the range of motion exercise for your chest wall, it can also be used to have a louder voice, to cough and clear, to blow your nose, or if you're getting sick with a cold or a chest infection, it'll help clear your lungs faster. It'll help prevent you getting sicker, might even prevent you from getting pneumonia, can help prevent having to go into hospital for intravenous antibiotics, can even help prevent you ending up intubated in the intensive care unit on a breathing machine to help you breathe. And if you are in the ICU, can help the mechanical inexsufflator or cough assist can also get you out there faster. I have some really impressive stories from my patients who have used the mechanical inexsufflator, and it has really made quite the difference in keeping them out of hospital, keeping them out of getting severe chest infections. And if they do have chest infections, they have an action plan. They know who to call. They have medications on hand at the pharmacy, and they have a respiratory therapist who can help their caregivers look after them in the home. And especially during our pandemic, it's really nice to be able to stay out of hospital. Of course, if you have to go, it's nice to be able to go there. And if you do have to go to hospital, make sure you bring all your equipment, your lung volume recruitment bag, or your cough assist if you have it, your Bipap machine, or your ventilator for mouthpiece ventilation if you need that. Because not everyone in intensive care units, respirology, or emergency medicine, or internal medicine have been trained or have experience with people with neuromuscular disease. So the other thing to take with you if you have to go to hospital is a health advocate who can advocate on your behalf. At this point, what I'd like to do is ask Pierre to speak to his experience with neuromuscular disease, breathing, coughing, and sleeping.
Okay, thanks, Dr. Janice. So I guess I'll tell you guys a little bit about myself before I get into some of the details or some things that I would like to discuss. So my name is Pierre Farage, and I have Duchenne muscular dystrophy. And I'm sure, as you all know, with muscular dystrophy, with the weakened muscles, unfortunately, that affects breathing and ability to cough. So I use three things. I think Dr. Janice mentioned all three of them. So I use a Bipap machine. So when I'm asleep, that machine does the breathing for me so I can actually rest well and wake up feeling refreshed. Now, before I used that machine, it was very difficult. Or I'd wake up and I wouldn't feel very refreshed. So that definitely helps quite a bit. And the blue bagger that Dr. Janice showed, I used to use that as well, but now I use the cough assist machine. And essentially, I found that a different staff or different people helping me. So each person squeezes the bag differently. So you never get that consistent cough throughout or the consistent expansion of your lungs. So the cough assist machine works a little bit better for that because you get the same amount of air every single time. And then I also use some mouthpiece ventilation, which helps for a couple things. Again, helps for expanding the lungs, and sometimes when you just feel like you need a little extra breath that you can't do it on your own. So that helps quite a bit. Retaining my respiratory health, just kind of like to piggyback off of what Dr. Janice was saying, getting the vaccine. So I think I get the flu vaccine every year, the pneumonia vaccine, and all that, all the fun vaccines that we have out there. So make sure to stay abreast of those. Again, avoidance of smoking. Obviously, it's hard enough to breathe, so you don't want to add obstacles or hindrances to make it even harder and harder. So don't smoke. Infection control. So, you know, if there is someone that's sick, although they might be, you know, your best friend, your buddies, family members, you know, if they're even slightly under the weather, just make sure that you stay away from them. And I know it's tough sometimes, especially now with this crazy pandemic, and it's a little harder to do that. I have a 4-year-old niece and a 2-year-old nephew, and it's very hard staying away from them. And you know, kids are always usually slightly under the weather, so It's very tough, but in the end, it really helps down the road. And another thing to have is it's good having a plan. So, you know what, if you have any concerns, it's nice to have, whether it's your family doctor, your respirologist, and your respiratory therapist, anyone, it's nice to have someone that you can contact, because with breathing and with the diagnosis, and we all know as muscles get weaker, it kind of affects us mentally. So it's nice having that support that you can always turn to somebody whenever you need any sort of help, whether it's something that's small, but you know, quite often we make a mountain out of a molehill. So it's kind of nice to be able to reach out to somebody that will just tell you, okay, yes, it's a concern, but it's not the end of the world. What I find very important is making sure that all those machines or exercises or whatever it is that you're using, make sure you use them regularly. It's just very easy to forget. So it's kind of nice to have some sort of tricks or some things to remind you when to use the different machines or the blue bagger or whatever it is that you're doing. Consistency, I'd say, is extremely huge. What else? I can show you guys the cough assist. How about we do that, and then I'll continue with that, because as you can tell, my voice is getting weaker and weaker, so I need get a shot of it. So this is my mother, and she's going to help me with the cough assist. So I'm going to leave the sound on as well, so you can hear the machine, and the first time you see it, it might be kind of funny. So get that. All right, that's the first time I've done that with an audience. But now, as you can tell, my voice is louder. I'm getting through a full sentence as opposed to 3-4 words in, stop, take a breath, and then speak again. So it's really good for that. And it wakes you up as well, gives you a nice like blast of air to kind of expand your lungs and help you out there. And again, water is very important. I'm already getting a little thirsty with all this talking, but anyways. So one of the things when, God forbid, we go to the hospital, quite often what you need to do is re-educate everybody. Because when you're going in there, everyone has like a specific set of rules or things that they're used to doing. But when you have a neuromuscular condition, then you kind of have to explain it to people what's going on. For example, quite often, I went in the hospital about 2.5 years ago for pneumonia, and I didn't have all my my toys like the Bipap machine, the cough assist, and the mouthpiece ventilator. And they wanted to basically do the cough assist machine, but they wanted to do like chest compressions, kind of, just to help move the the secretions out of my chest. And instantly I was like, nope, please do not do that. And they're like, oh, we can put a pillow and that sort of thing. But even with that, it doesn't help, because God forbid they crack a rib or something, and that just gives you more problems. You're not able to, have a deep breath anymore, and it's very difficult. So God forbid you do end up going to the hospital, just make sure you tell them to be careful. Because I actually had a nurse or respiratory therapist try to do the cough assist, and then he put a pillow over my chest and he says, this is what I would usually do. And there was a little crack sound. So I was like, okay, so let's not do that at all. So it's very important because each one of us is different. So you have to explain it to them to make sure that they're doing it properly. And it's very easy to learn. So like, I know these people go to school and that sort of thing for these sorts of things, but it all depends on my own personal comfort level. And that's pretty much all I have to share. So I know if Dr. Janice, if I missed something you'd like to ask, by all means, go ahead.
I'd like to add on to what Pierre said, especially during this pandemic, because using lung volume recruitment, the LVR bagger, using the mechanical inexsufflator or cough assist, and using BiPAP or mouthpiece ventilation, these are all aerosol generating medical devices, which means there's the potential to spread COVID-19 if you are sick with COVID-19. So right now, all the hospitals, all the emergency rooms are very, very leery about having people use their equipment in the emergency room. And not everyone will understand that having a neuromuscular disease that requires lung volume recruitment, cough assist, or BiPAP, or mouthpiece ventilation, or daytime BiPAP, isn't an option. It's not like you have sleep apnea and you're going to be okay if you forgo your, you can't do without your equipment. And that if you don't do your LVR exercises, either with the apparatus or the machine, if you don't have your BiPAP, you don't breathe with your BiPAP, you're not breathing, you're not clearing, you're not coughing, and you're not getting over your pneumonia, you're just going to get into more trouble. So it's very important that you take your equipment with you and that you insist that not breathing is not an option. My number one, Pierre knows, my number one saying is breathing's not an option until you're 6 feet under. You're not 6 feet under, you got to breathe. In and out, day and night, when you're awake and when you're asleep. So especially during these times of COVID, if you do have to go to hospital, it may be a really good idea to call in advance or to have your doctor or your respiratory therapist call the hospital in advance. And if it's deemed that you really do need to be admitted, there may be a way to triage you directly to a hospital bed on the ward, if there are beds, instead of having to go to the emergency room. Of course, ideally, if you can be proactive and preemptive and hop on an illness right away, get onto treatment right away. My hope is always that hospitalization can be avoided, but sometimes it's not. And sometimes you're doing everything right, you're doing everything possible at home, but you just need that intravenous antibiotic. You just need that extra hydration through the intravenous. You just need that extra manpower to help you cough and breathe. And it could be that you end up needing to go in for something totally unrelated to pneumonia or your breathing. Might be something else, gallbladder attack or who knows what, kidney problem. So keep in mind, you know yourself best. You need to know yourself best. Bring your equipment and have a health advocate. If you don't have a health advocate, feel free to bring the telephone number of your respirologist or your neurologist with you and tell the internist or the emergency room doctor or the intensivist, please call my specialist. Is there anything else that you want to add to that, Pierre? Oh, also be aware, know in advance what you want and what you don't want. If you know that, if things get really bad, your breathing gets really into big trouble, you're okay with going to the intensive care unit, you're okay with being intubated, you're okay with being trached and being on invasive ventilation. Know in advance what your wishes are should things go south, and have that written down somewhere, formalized with your doctor, your family doctor, or your specialist, and make sure that your healthcare advocate can speak with you, for you with your voice, just in case you don't have the ability to speak for yourself and express your wishes and preferences. And make sure that If you don't want to be intubated or trached, that this is clear, because I have had some patients who showed up who were admitted for pneumonia on the pulmonary ward, and the next thing they knew, an anesthetist was coming up to see them because they were scheduled for a tracheostomy the next day, and the guy's going, I don't want that. So please make sure you know what you want, what you don't want, and this is written down, and if not written down, that you have a healthcare advocate who speaks for you if you can't speak for yourself. Is there anything else you'd like to add to that, Pierre?
No, nothing. That's very important. What you finished off with, know what you want and make sure that either you can communicate it or someone can communicate it for you.
Excellent. Thank you so much, Dr. Janice and Pierre. I do see some questions, so perhaps we can get to those. Any advice to deal with laryngospasms, choking, or also called dry drowning?
So is this laryngospasm that's happening in the context of swallowing food or drink that then triggers laryngospasm, or is it just out of the blue? If it's something that's triggered by abnormal swallowing of liquid or food, then I do recommend you do your lung volume recruitment exercise before you eat. Safe swallowing, no distractions, all the recommendations your speech language pathologist will have for you. You may need to have a formal assessment by a speech language pathologist and an ear, nose, and throat specialist. There are some tricks that you can use to get out of laryngospasm with that, or by breathing through your nose. And the most important thing, of course, is staying calm, but laryngospasm can be very scary. If it's something that is triggered by food and drink, then it may be a good time to have your swallowing reevaluated with a formal swallowing assessment and considering alternatives to oral eating. Remember that with alternatives to oral eating, in other words, having a feeding tube, doesn't necessarily mean that you stop doing the fun stuff of eating or tasting. But what's nice is that the feeding tube can do the things that are work, the work of making sure you're well hydrated, the work of having enough nutrition, the work of swallowing those pills. Gee, if I had a feeding tube and I wasn't bad with the swallowing, I would use it for ingesting pills in a heartbeat. And when you have a feeding tube, it's still possible to taste food or have some pleasure eating. Again, these are things to discuss with your speech language pathologist. And if you have a cough assist, then if something goes down the wrong way, something that could a situation that can potentially trigger laryngospasm, you've got that cough assist to immediately on preset 3 for respiratory crisis to get that irritation up and out and help you get on with your day. So in terms of laryngospasm, yes, there are tips and tricks to help deal with that. The best thing to do is to avoid the triggers for your laryngospasm, and that may need a formal assessment by a speech language pathologist and a ear, nose, and throat specialist or otolaryngologist.
Good. Another question is, can a cough assist machine be used to stretch our lungs instead of the LVR or the blue bagger? And where do you get the LVR from?
Good question. Absolutely, the cough assist can be used for lung volume recruitment or breath stacking. And in fact, it can also be set with just the positive pressure because the lung volume recruitment bagger only gives positive pressure. The cough assist, we can actually set to have negative pressure, and the cough assist or the inexaflator can be used just for positive pressure to do the stretching of your chest wall to open up your lungs. And as Pierre mentioned, what's really nice about the cough assist is it's easier for caregivers to use, and from the the person who's getting the treatment, it's more consistent treatment. So it doesn't matter who's doing it. As long as the seal on the face is firm, you're getting the same treatment. You're getting the same intensity of therapy from no matter who's delivering your therapy. So that, yes, the cough assist can be used for LVR.
Very good. Perhaps I can ask the next question around cough assist. Does the patient try to cough or let the machine do the cough?
Two things. If you have the ability to do some coughing, you can actually coordinate with the machine to augment the cough, either by what you do yourself by the therapist, your caregiver saying, okay, it's now going, or you can watch it on the machine when it switches to the cough, to exhale mode. You can cough with it for a more effective cough, or your caregiver can give you a manually assisted cough. If you have no ability to cough with the machine on the exhale cycle, your caregiver or you can give yourself a manual assisted cough to augment the intensity or the force of the exhale to get a more effective cough. There was also, I just realized I didn't answer the question where you get this. This is usually obtained through the Bipap or oxygen companies. It's called a lung volume recruitment apparatus. And it costs anywhere from $65 to $85. It's covered, if you're in Alberta, it's covered by AISH. And I would assume that it's covered by similar agencies in other provinces as long as you have a doctor's prescription. But it's something that you don't just take and use on your own. You should have a respiratory therapist or a physiotherapist teach you how to use this. There's an excellent website, CanVent Ottawa website that has some videos as well as some slideshows on how to effectively cough and clear. The cough assist is much more expensive. It's a much fancier, delancier gadget. It's about $4,500 to $5,000. It is covered in 5 provinces. It is not covered in Alberta. Thank goodness for Muscular Dystrophy Canada and their equipment grant. Our patients here in Alberta can obtain the cough assist with help from the equipment grant. But I believe it only covers up to $3,000, and then you can use either if you have independent funds or petition other agencies to make up the difference. But it is something I feel strongly. It is the mechanical cough assist. It's worth its weight in gold. 1, because it is effective. 2, it keeps people out of hospital. And if a person goes to hospital with a chest infection, you're not going in there for 1 or 2 days. You're probably in there for 7 days to 3 to 4 weeks, which more than covers enough cough assist for quite a few people. If you figure, 2 days in hospital covers the cost of 1 cough assist.
If I could piggyback on that, sorry, I didn't mean to interrupt, but
no, please do.
The 3 machines that I use between the Bipap, cough assist, and the mouthpiece ventilator, I think the cough assist is probably the best one. Of course, they all have their different purposes and different benefits, but I find the cough assist, especially in an emergency situation, that's your guardian angel, basically. If you're having trouble, something went down the wrong pipe or whatever, that cough assist really helps to get it out. And it is very expensive, but thank God for Muscular Dystrophy Canada, because great commercial, by the way. It helped out, because of the funding, it allowed me to get the cough assist machine, and that's just been a godsend, to be honest.
And Pierre, are you willing to share when was the last time you were in hospital? How long ago?
That was January 2018, and I was there for 2 weeks because of pneumonia. Sorry, because of pneumonia.
Coming up on 3 years of you, almost 3 years of you staying out of hospital, which is phenomenal. Never mind the cost of the cough assist or the cost of staying in hospital, the cost of staying out of hospital, as the MasterCard ad says, it's
Yeah.
priceless.
Yeah.
Absolutely priceless.
Definitely.
That's great. A question that I'm seeing on here is around preventative or being proactive. So would someone get a bag or a cough assist even if they didn't have issues to help keep their lungs strong? So an individual who has a neuromuscular disease, not experiencing any respiratory distress or concerns right now, could it be used proactively?
I base my prescription for the lung volume recruitment bagger on what is the vital capacity? How big a breath are you taking? Is it, 100% predicted for your age, height, weight, size, gender, ethnicity, or is it declining? If it's declining, absolutely start it. I would start those exercises. Even if you have, if someone has a normal lung volume that they can inhale on their own, but they're at risk for choking because the muscles that affect swallowing are affected by their neuromuscular disease. That's also when I start the lung volume recruitment exercises. We know from studies in ALS that somehow the lung volume recruitment bagger facilitates a better swallow. Not exactly sure how that works, but we know from the studies by Stuart Cleary that yes, the swallow is more effective. So if swallowing is at risk, if choking is a real possibility, absolutely. I want you to start LVR exercises and I want you to have a choking action plan. I want you to know how to do a manually assisted cough. I want your caregivers to know how to do a manually assisted cough. And yes, this makes a huge difference in one, keeping you healthy, being proactive and being preventative for crises. But the other thing is that as uncomfortable it is for you to feel like you're choking or not being able to take a deep breath, it's also very distressing to your loved ones to see someone choking or looking out of breath. And being able to help someone is as important as being able to have that help.
Thank you very much. Another question that's surrounding around this preventative, proactive care or nature is if the individual is talking about their son, 12 years old, ambulatory, and wondering whether exercises like breath stacking should be started early. Breath stacking 4 times a day is quite a lot, but if it should be started before problems begin, that would be good to know.
Again, it's related to their pediatric respirologist assessment of their respiratory status. Are they at risk for choking? Are they at risk for problems with swallowing? And it could be that doing the lung volume recruitment exercises twice a day is enough for someone who's early on. We don't really know. I just know if someone is at risk because of low lung volumes, having a choking spell, or if something goes down the wrong way of getting into serious trouble, 2 minutes of 5 deep breaths, 5 maximal breaths before mealtime, that's easy. Sometimes some of my people that I look after, they do it twice a day and they're fine, but when they start to get sick, they do it to 4 times a day. And if they're really sick, they're doing it 10, 20 times. And that's to help cough and clear. But some people, like Pierre just demonstrated, you can use breath stacking either through the lung volume recruitment bagger or the mechanical enaxoflator or cough assist, or through mouthpiece ventilation. You can do breath stacking just to have enough breath to talk. I really enjoy talking. If I ran out of air, I wouldn't be very happy. So I'd hate for my patients or anyone I'm talking with or listening to, for them to run out of breath or not have the ability to tell me what they're thinking, what they're feeling, what they want to communicate to me.
Can you tell us with the cough assist about the settings again? So what settings would you prescribe for the cough assist? The settings are and this is still a relatively new concept in neurorespiratory care.
especially since the cough assist that's out now is a very fancy Delancey machine with all sorts of bells and whistles. You know, not only can I set 3 settings, I can adjust the inhale, the exhale, the time for inhale, the time for exhale. If you can't trigger the cough assist to give you that inhale, I can have the machine I can program the machine so it just gives the breath. I can also have the machine do internal chest physio. I can add an oscillation function. I can set how intensely that machine oscillates, so the amplitude, the frequency. I can set it for its inhale or exhale. So it's not just about what numbers do I pull out of the air. It's something that I actually have to work with you to find out what are the best settings for you. Is this something brand new for you? Because if I right off the bat give you what the most, effective settings as per the textbooks, plus minus 30 to 40, and you've never done lung volume recruitment, you're going to go like most people in hospital. They say, oh my goodness, that feels awful. I don't want to use that. So it's a matter of, just like you get used to BiPAP, finding the right settings, finding the right mask, finding the right flows and pressures, you need to find the right settings with the cough assist to meet your needs. And early on, when I'm just starting, I might have a set of 3 settings to start with. And then as time goes on and you get used to the cough assist, I might need to adjust. So that setting 2 becomes setting 1, or setting 3 becomes setting 1, and now I have to add on extra settings. So it's not something I can just pull out of the air. I do have a PowerPoint presentation on how to determine those settings. If anybody's interested, I'd be happy to share those. Or if respiratory specialists would like to have a talk specifically on how do you set up those settings, how do you determine those settings, I'm happy to give that talk.
Very good. How about we take our last question, and I'll ask my colleague Véronique that she'll read the last question in the Q&A. Go ahead, Véronique.
Oui, parfait. Alors, on a une question ici. L'utilisation du RVP pour les risques d'étouffement sont utiles avant de manger, seulement en prévention ou bien pour aider à dégager aussi si ça arrive? Et y a-t-il également des risques de pousser les aliments un peu plus loin en tentant le RVP?
Excellent question. The reason I recommend before, it should be done within 30 minutes of eating. And because the effect of lung volume recruitment only lasts about 60 to 90 minutes. And if you think about it, I'm just going to show you, if I'm about to eat and my lungs aren't fully expanded, I'm going to feel full more readily, and I'm not going to be as expanded to be able to cough and clear if something goes down the wrong way. So if I do my lung volume recruitment, my lungs are at a new reset point. I won't feel as full as readily, and I'll have a little more air in case something does go down the wrong way. We don't recommend doing it within about an hour of eating, because of the risk of reflux aspiration. However, if something has gone down the wrong way and you are choking, absolutely use this as a method to get out of a choking spell. And you ask a good question, well, if I'm choking on some food, isn't it going to go down deeper? Isn't that going to push it down deeper? Yes, but think about it. I have a normal ability to take an inhale and cough. What is the first thing I do when I'm choking on something? The first thing I'm going to do is take a deep breath. And yes, I might suck that obstructing food item a little deeper, but most of the air hopefully will get behind, increase the lung volume, and now I'll have more air to be able to cough it out. So the natural reflex, the natural response to choking is to take a deep breath. But when you have neuromuscular disease, you can't take that deep breath. So that's where the bagger comes in. And the same thing with the cough assist. The cough assist may push that object that you're choking on a little deeper, but it's going to suck it out. Most of the air that's being pushed in is going to go behind or around whatever you're choking on. And then there's that air to suck out whatever you're choking on.
And there's even an emergency setting, or one of my settings is honestly like a vacuum. You just put it to your face and it just blows air and sucks it right out. So having that setting really helps as well.
And the machine has a really user-friendly platform.
Excellent. Well, I wanted to thank Dr. Janice. I would like to thank Pierre for really a good talk, a practical talk, and for taking the time to answer questions. I want to echo what Pierre said. Having that emergency care plan is important. We had a webinar over the summer on preparing an emergency care plan. And we have alert cards as well at MDC that you can download and include that information. Thank you so much, Dr. Janet, for your ongoing support. And I welcome you all to attend our next session on balance and falls, vestibular health, and neuromuscular disorders. Thank you all so much and see you all soon.